Bismillah ar-Rahman ar-Rahim. Our topic today is to clarify how to clinically examine a patient with knee osteoarthritis. There are general rules you should do before starting examination. First, you should wash your hands, introduce yourself for your patient to gain his confidence, confirm patient details and information's ID, explain examination and test you are going to perform for the patient before starting, expose the patient legs, and in case of knee examination, your patient should be wearing shorts. Ask if the patient has currently any pain before starting examination. The main component of knee examination will include inspection, palpation, movement, passive and active, special tests. This is an image just to remind yourself by the most important points and parts that you are going to palpate and examine in the knee. For inspection, you should inspect your patient while standing, walking, and lying supine. While standing, assess the gait of the patient, whether it is smooth and symmetrical, and observe any obvious abnormalities. For example, the antalgic gait, where the patient is suffering from arthritis in one limb, for example, acute synovitis on top of chronic osteoarthritis, so the patient cannot bear the pain while he is doing weight bearing on the affected limb. Check for any deformity in the knee, for valgus deformity, what we call knock knee, varus deformity, bow leg, and genu recurvate. And don't forget to look for the popliteal fossa for the presence of any swellings. The right image, there is a swelling on the back of the left knee in the left popliteal fossa, most probably Baker cyst. The deformities of the knee, here is the varus deformity and the valgus deformity. Then ask the patient to lie supine on the couch and observe for the presence of swelling, and you should determine whether the swelling is diffuse or localized, intra-articular or extra-articular. Diffuse swelling, I mean the whole joint, so most probably it is effusion, and usually it is intra-articular diffuse swelling. For localized swelling, it is due to extra-articular structure, for example, tendons or bursitis. Check for skin lesions or discoloration. Skin lesions, for example, if your patient is suffering from psoriatic lesion, or discoloration like redness or erythema. For differential diagnosis of acute synovitis on top of chronic osteoarthritis, the patient may have acute gouty arthritis, in which the skin, usually there is erythema overlying the skin, overlying the affected joint. And redness is part of inflammation in arthritis, whereas the joint should be hot, red, tender, and there is limited range of motion. Check for scars, whether your patient has done any previous operation, like arthroscopy, for example, and notice if there is any quadriceps wasting due to prolonged pain or immobilization, in which there is disused muscle wasting or atrophy. This is diffuse knee swelling involving the whole knee joint. And this is wasting of both quadriceps muscle. It is more evident on the vastus medialis. Then we move to palpation. First, check for hotness. You are going to check for hotness by the dorsum of your hand, starting from proximal to distal, I mean from the mid-thigh to the knee joint. Hotness for arthritis or for inflammation. Then check tenderness over the quadriceps tendon while the knee is extended. While the knee is semi-flexed, you can check for the margins of the patella and the patellar tendon for irregularities or tenderness. Check for any tenderness or swelling or irregularities over the tibial tuberosity in case of Osgood-Schlatter disease. Head of the fibula for tenderness. Check for tenderness over the medial and lateral part of the joint line, femoral and tibial condyles, the origin and the insertion of the medial and lateral collateral ligaments, and for sure any swelling in the popliteal fossa or tenderness in the popliteal fossa, where it may be a Baker cyst or popliteal bursitis. These are the points you are going to check for palpation and for tenderness in the knee joint. And don't forget to measure and compare quadriceps bulk bilaterally, starting proximal and point proximal to 20 centimeter proximal to the tibial tuberosity. Proximal to the tibial tuberosity, 20 centimeter. And compare both sides for any wasting. For movement, we are going to do active range of motion and passive range of motion. For active range of motion, you are going to ask the patient to do the movement completely by himself without any assistance from you or from the doctor. You are going to assess the range of motion, the smoothness of motion, pain at movement, and the occurrence of crepitus if you can hear it, and lateralization of the patella. You are going to ask the patient to fully extend and flex the knee. For flexion, ask your patient, please move your heel as close to your bottom as you can manage. And for knee extension, you are going to ask your patient to straighten his leg out as best as he can. For passive range of motion or passive mobilization, this involves that the patient is completely relaxed and you are going to do the movement by yourself. You are going to hold the ankle by the right hand and put the palm of your left hand over the knee joint or over the knee joint line and do full flexion and extension of the knee. And try to feel the crepitus, and you should differentiate between the crepitus in patient with knee osteoarthritis and in patient with rheumatoid arthritis. In case of knee osteoarthritis, the crepitus is coarse crepitus, while in patient with rheumatoid arthritis, the crepitus is fine crepitus. Then complete the movement in flexion and extension and try to observe any restriction of movement, for example, if the patient is suffering from flexion deformity. For the special test, we are going to check for two parts, for the joint effusion and for the integrity of the knee joint ligaments. For joint effusion, we have two tests. One for the moderate effusion, the patellar tap test, and one for the minimal effusion, what we call the fluid displacement or cross fluctuation test. For the patellar tap test, while the patient is lying supine with the knee extended, with your left hand, try to squeeze the suprapatellar pouch downward toward the joint line in order to try to accumulate any minimal amount of fluid underneath the surface of the patella. And with the tips of the fingers of your right hand, try to tap sharply over the patella against the femoral condyles. In cases of moderate effusion, the collected amount of fluid underneath the surface of the patella or between the inferior surface of the patella and the femoral condyles, while tapping, you will feel like the patella is floating or there is some sort of ballottement during tapping. That's why the patellar tap test also called the ballottement test. For minimal amount of effusion, there is cross fluctuation test or fluid displacement test, or what we call the bulge sign. The patient will lie supine with extended knee. You are going to stroke upward with the edge of the hand on the medial side of the knee in order to milk the fluid for 10 centimeters proximal to the patella into the lateral compartment of the knee joint. And then continue pushing the fluid downward on the lateral side. Then push from the lateral side and try to notice any bulge due to accumulation of the fluid or movement of the fluid toward the medial side again. For the integrity of the ligaments of the knee joint, we are going to do two tests for the cruciate ligament and two tests for the collateral ligaments. Test for cruciate ligaments, we have anterior drawer test to assess the integrity of the anterior cruciate ligament and posterior drawer test to assess the posterior cruciate ligament integrity. The patient will lie supine with the hip flexed 45 degree and the knee flexed 90 degree and stabilize the feet over the couch. Even the doctor can sit over the toes. And then try to grasp the tibia just from under the knee joint. In case of anterior drawer test, you are going to pull the tibia anteriorly. And the test is positive if there is excessive anterior translation of the tibia more than the healthy side or the other side. In case of the posterior drawer test, you are going to the same position of the patient and you are going to grasp or pull or you are going to push the tibia backward in order to assess whether there is tear in the posterior cruciate ligament or not. If there is a tear in the posterior cruciate ligament, there will be excess translation posteriorly more than the other side. For the collateral ligament, we have the knee valgus stress test and knee varus stress test. In this test, the patient will lie supine on the table, the lower thigh rests on the table edge, and the legs hangs off table. There are two positions to assess the collateral ligaments. Either with the knee completely extended, 0 degree, full extension, or while the knee in 30 degree of flexion. And in case of flexion, it is more accurate to assess the collateral ligament because in full extension, the knee is already stabilized by the posterior cruciate and the bony articulation. After stabilizing the lower thigh with one hand, apply gentle stress at the patient's ankle or foot. Valgus stress test for the medial collateral ligament and varus stress test for the lateral collateral ligament. This is a valgus stress test, and notice that left hand of the doctor is on the medial aspect of the knee. This is a right knee, and he is trying to push the knee toward the medial aspect or inside. If there is tear in the medial collateral ligament, you will notice a slight opening in the medial side of the joint line. For the lateral collateral ligament, there is varus stress test where the left hand of the doctor is on the medial aspect of the knee trying to push out. And if there is lesion in the lateral collateral ligament, there will be a slight opening in the joint in the lateral aspect of the joint line. Please watch this video for further details about the clinical examination of knee osteoarthritis, and thank you for your time.